Good afternoon, everyone. Welcome to United Hospitals, Jayanagar, Bangalore. Today we have Dr. Lingaraju A.P, Senior Consultant Orthopedics and Joint Replacement Surgeon. Welcome, sir.
Thank you. Thank you.
Here we are discussing about osteoarthritis of knee and its treatment. Sir, what is osteoarthritis of knee?
Osteoarthritis of the knee, the so-called the wear and tear of the knee joint. Wear and tear of the knee joint usually commonly seen in the elderly, females after 50 years or males after 60 years due to the cartilage thinning out, and over a period of time the cartilage starts wearing out, exposing the bone and starts causing the pain. So this is classically described as the osteoarthritis actually. So arthritis usually is a general term. So we commonly describe like arthritis of the knee, or common the knee pain, or in Kannada we call it as Vayu or Sandhi Vata. So there are different types. One is the inflammatory arthritis. Basically this is due to the common conditions like rheumatoid arthritis or the systemic lupus erythematosus or psoriatic arthritis. So to name many are there. These arthritis we commonly seen in the little younger age group, and this is a multi-joint involvement, means it involves more than 2 to 3 joints in the body, having different multisystemic involvement, early morning stiffness and all those multiple factors. That's called inflammatory arthritis. Whereas in osteoarthritis is classically involves the weight-bearing joint like knee joint, and that's commonly seen in the elderly. That is the two different types of arthritis.
What are the causes of osteoarthritis?
Yeah, osteoarthritis, when you're talking, basically one is usually we commonly come across females after 45 to 50, males after 60. One of the very commonest causes is the sedentary lifestyle. And the second commonest cause is the obesity. Actually, these two are the commonest causes. A lot of people think that actually if we walk too much, our knees will wear out early. And if you don't walk, we save our knees. Actually, it's a wrong concept. More we do the exercises, more we active, our knees will be in a very good condition. Basically, because there's something called as lubricating fluid in the knee, so which will keep circulating in the knee joint as we are active. Once we are sedentary, the lubricating fluid comes down, the cartilaginous matrix thins out, so then that leads us to the osteoarthritis. So to name mainly is the sedentary lifestyle, the second is the obesity.
What age groups are affected, sir?
As I said, commonly in females, they start after like 45 to 50 years, they start noticing the pain, the swelling, deformity. In the males after like 55 to 60 years, so again the same symptoms on this one. Yeah.
Why it is common in females?
Yeah, females, so one is what happens is when there is a little hormonal disturbances starts happening during their menopausal time. So there is a very important structure called cartilage in the knee joint. So this cartilage is the cushion for the joint to take the load and to basically avoid pain in the knee joint. So this cartilage helps in the smooth functioning, smooth movement of any joint in the body, and especially the knee joint, since knee joint is being the load bearing joint, so this cartilage is very important. So this cartilage, what happens is because of the hormonal disturbance, one, and second thing is most of the females starts the weight gain after like 45, second, third is the sedentary lifestyle. So these three slowly adds on to the problem of thinning out of the cartilage, and then over a period of time the cartilage naturally, which is around 4 to 5 millimeter thickness, starts becoming 3 millimeter, 2 millimeter, and here and there it starts becoming specks of the wear, and that over a period of time it progresses to increase at a bigger lesion, and that will lead to the arthritis in the future. So that's why it's more common in the females. To take a ratio, we say 80 to 20, means we see 80% of the females, 20% of the males. The ratio is in 10 population, so 8 females and 2 males. So that's what the commonest.
What are the preventive measures we take to avoid osteoarthritis?
Yeah, main preventive measure is the weight control, and second preventive measure is the regular physical exercise and keep your knees in a good condition. and exercise is the main stay of the preventing the osteoarthritis. And a lot of people actually they say the osteoarthritis runs in the hereditary. Actually, it's not true. Sometimes what happens is the mother is suffering from the severe osteoarthritis, and then the daughter starts noticing the pain at 35 to 40, and then the common thing which is their mind is actually, oh, it's hereditary. No, osteoarthritis per se, it is not hereditary. So again, hereditary, that inflammatory arthritis, as I mentioned, the rheumatoid arthritis or psoriatic arthritis, other types of arthritis runs in the hereditary, but not osteoarthritis. So the main way of prevention of osteoarthritis is the weight control and regular physical exercise.
How to grade osteoarthritis?
We grade osteoarthritis mild, moderate and severe. So mild usually we seen in the little younger age with minimal pain symptoms and mainly the stiffness in the knee joint in the mild phase, and the pain is not constant. We see occasional pain when they are little overstrained or exertional pain we see on the mild symptoms, and these most of the can be diagnosed early. In the moderate stages, the pain becomes little more significant, the on and off swelling in the knee joints, and then you may notice the difficulty in climbing stairs and sitting on the floor, using commonly the Indian style toilets. So these we see in the moderate stages. In the severe stages, again the disability gets progressed furthermore, it gets worsened more, and finding difficulty in doing our regular day-to-day activities like standing, cooking, and even to do our regular toilet activities, we find the difficulties. Even to do our routine social working also, we find unable to do it, and we get little housebounded. So this is the severe osteoarthritis. This is mild, moderate, and severe osteoarthritis.
What are the treatment options at early stages?
Yeah, mild early stages, we again mild and moderate stages. Most of these can be managed with the medications. So medications, we start the medications to strengthen the cartilage. So basically there is something called as a cartilaginous matrix which is formed of the collagens. Collagens is basically the main structure which supports our the cartilage structure. So we start on the medications to strengthen collagen preparations or the glucosamine preparations to strengthen this cartilage, and this will prevent the further wear and tear of the cartilage to some extent. That is one. And then we started medications to increase the lubricating fluid in the knee joint. Again, decrease in the lubricating fluid is again one of the commonest reasons for the early wear out. That's we commonly call it as a dry knees. Dry knees means, when a simple example to give you, when you have our dry lips, usually what we do is we wet the lip or we put our lip moisturizer. So unless we wet the lip, we have a discomfort, pain, something. Same thing happens in the knee also. When there is a little dryness in the knee, especially the kneecap, it starts giving the pain and it starts giving the stiffness. So that and cartilage dryness, which will lead to progress in the wear and tear of the knee joint. So that is in the mild to moderate stages. Majority of them do the medications, and sometimes when there is an acute pain, you can do high SPAC applications on the side of the knee. When there is little chronic pain, we can do heart fomentations on the side of the knee, and proper physiotherapy to decrease the swelling or the edema on the knee, and then the proper physiotherapy to strengthen your knees. Main important is knee strengthening exercises, and some preventive measures like avoid sitting on the floor, avoid excessive knee bending, for some days avoid stair climbing and straining on the knees. So these are the mild stages.
What are the indications of intra-articular injections?
Yeah. So intra-articular injection is one of the very common procedure done in the knee osteoarthritis, and done in a very selective patients, it responds very well. So the common indications, as I mentioned, one is the when there is any swelling in the mild to moderate stages, we can give injection intra-articularly to decrease the inflammation in the knee joint. So that will help in the healing. So the second common injections, a lot of other varieties like we use the platelet-rich plasma injections, PRP injections. So this injection we prepare from the patient's own blood. We draw around 20 ml of the 20 to 50 cc blood. We extract platelet-rich plasma in that blood, which is known to have a healing potential and helps in the healing of the synovial tissue and even helps in the healing of the cartilaginous tissue in the knee joint when there is a little wear and tear. So this is PRP injections. So these mild to moderate stages, actually PRP injections will respond well. In the severe stages, PRP injection does not have any role. Again, with this, when there is any more involvement of the, we have a patellofemoral arthritis, means the main wear and tear is between the kneecap and the thigh bone. In those patients where the main complaints will be like sitting and getting up is a problem, stair climbing is a problem, and then the sitting on the floor is a problem, and walking for long distance is a problem. In such patients, we use the so-called intra-articular hyaluronic acid injection. So this hyaluronic acid injection usually it comes as a preparation of an inert gel preparation, and given intra-articularly, what happens is it coats the cartilaginous structure in the knee, and it's like basically polishing. Once there is a coating on the thick cartilaginous structures, the underlying cartilage usually starts healing. So you are giving adequate rest for the heal also. And again, you are lubricating the joint with a thick viscous material, so which is also helps in the improving your knee mobility, improving the walking and other activities. And again, this given in a selective patients like more of patellofemoral arthritis or in the early to moderate arthritis, patients do respond very well to the treatment. And once we are given these injections, usually patients respond well for the sometimes 1 to 2 years, and if necessary, we may have to repeat after 2 years based on the patient conditions.
What are the surgical options and its indications?
Yeah. Surgical options ranging from the we have a simple the so-called the arthroscopic surgery. Arthroscopic surgery is the called keyhole surgery. In this keyhole surgery, when there is any moderate to early arthritis with the focal cartilaginous defects, means there is a small loss of the cartilaginous in the knee. When there is a focal cartilaginous defect and a lot of the synovial tissue in the knee joint and a lot of the debris in the knee joint. So what we do is this is basically called as the knee joint lavage. Lavage is basically cleaning up the debris and removing all the unwanted things, one. And second thing is wherever there is a cartilage thinning or this one, fibrillations, we clean up the cartilaginous fibrillations. So that helps in the healing of the cartilaginous with a new fibrous tissue, so which will prevent the further wear and tear. That's one of the commonest procedure we do, again in the moderate to early stages of the arthritis. So this procedure actually what happens is we will prolong the wear and tear of the knee joint. So maybe 8 years, 10 years, 15 years, so the patients will be comfortable enough to manage their activities. In the future, if the wear and tear progresses, then it's a different. The second common surgery we do is the knee deformity corrections. Knee deformity corrections we use when there is any one compartment of the knee is involved. So when the knee is, so then we do shift the weight. An example, when there is any inner compartment of the knee is involved, so we shift the weight to the center and the lateral compartment, means the outer compartment. When you shift the load, so automatically the inner compartment starts healing and the wear and tear will stop and the patient will be comfortable. So this is called as a deformity correction. So in this actually we are going to cut the small portion of the bone and bring the correct alignment and bring it to the neutral position and then fix the small plate. So that's the commonly called as a high tibial osteotomy. That's called deformity correction procedure. And third is the when there is any, as I mentioned, the one compartment of the knee is involved. So we are doing what is called as the partial knee replacement. Partial knee replacement means we do only replace the only one compartment of the knee. So when there is involvement in only one compartment, and that's also again when the other compartment is fine, so the patient will get back to their normal activities very quickly because this is the simpler procedure than the total knee replacement.
Sir, what is total knee replacement?
So total knee replacement is basically in the knee We have the three compartments. Basically, in the leg we have two compartment, and then the patellofemoral. When all the three compartments are involved, so basically the tibiofemoral compartment, the patellofemoral compartment. So when the three compartments are involved, so then the standard procedure of choice is called the total knee replacement. So in this, basically we are replacing all the three compartments of the knee. That's why it is called total knee replacement. In the procedure earlier, we replaced only the one compartment of the knee. So that is called partial knee replacement, or in called as a unicondylar knee replacement. So this is a total knee replacement.
When do people require total knee replacement?
Yeah. Mainly we go with the patients, the complaints that when the disability is more, when the patient says that I'm not able to do my regular activities, I'm not able to do the regular walking, stair climbing, finding difficulty in doing my outside social activities. So then it's the time to take a decision for the knee replacement surgery from the patient perspective. From the surgeon's perspective, basically we grade again the X-ray wise, we grade that into mild, moderate and severe. When there is involvement in both the compartments of the knee joint with lot of the extra bone growth in the knee, there's a completely loss of the joint space in the knee joint, and there are a lot of osteoarthritis grown inside the knee joint also, and then that's the stage for the knee replacement.
Any age group limit is to be undergone total knee replacement?
Actually, there is no age. Actually, we no age limit for to undergo the total knee replacement. It is mainly the what we say is the physical fitness is more important than the patient's age. In simple, we say the physiological age is more important than the chronological age. In the sense, somebody who can be like 80, 85 is very fit, so he is fit enough to undergo a surgery. So somebody who is like 55, 56, he has more of medical issues, lot of comorbidities. So, but even though his age is less, he is not fit for surgery. So the main fit indication is the physiological, what is the fitness. The physiological age is most important. Nowadays we are doing a lot of patients even at the age of 85, 86, 90 years also. Even actually, to give an example, we have done the eldest in India. We operated on a 93-year-old who did his both knees replacement surgery about 7 years back. And to just share his history, he was so comfortable and he was walking daily about 1 kilometer. He was back to normal totally. And for us, unfortunate actually, in fact, he was able to celebrate his century in 6 months down the line, but he died due to COVID. So, means he was happy for the rest of his life. He was operated at age of 93 and he crossed 99 years. So, age is not the criteria. So, it is our health condition and then our physiological body fitness is what is more important.
What are the latest advances in total knee replacement?
So, knee replacements, one is we have advanced in the many aspects. One is the first and foremost to give you our surgical techniques have a lot of change. We use the so-called the computer assisted navigation technology. In this we use a very small incision, means we open a very little and then very minimal blood loss in this procedure and very minimal pain. Usually, and majority of the patients will ask us, oh, have you done the surgery on me? Because their expectation was on the pain was different, but here they are not feeling pain at all. So and are very early recovery to their normal life. So these are the 4 important parameters. One is the very minimal pain, very less incision, minimal blood loss, and very early normal recovery to normal life with this technology. So that is advance. And then again we have advanced the implants. We have advanced the implants saying that actually the current technique and then the current implants what we have, so usually the knee at least it will survive for about minimum 25 to 30 years. So an example, if the patient is getting operated at the age of 65, so we can rest assured that rest of their life they will not have any issues with the knee, provided they maintain their bone quality in a good condition. So that's surgical advances. The implant also, the longevity of the implant has advanced, and there are a lot of advances in the so-called insert in the knee joint, which is a lot of the newer versions, which will even expected to live longer, more than 25, 30 years. So that's it. And more importantly, the pain. So usually we have a lot of advances in the pain management systems. The anesthesia team actually uses the lot of the regional anesthesia. They use adductor blocks. They give a small local blocks on around the knee. So that will take away that will minimize the lot of injections to be given during the post-surgical period, which will have some side effects. So that way, and the pain we can say is very, very minimal. So the patient majority of the times will be morning surgery, evening we can make them walk and stand. So that is the latest advance. So they usually
How safe is total knee replacement?
Yeah, nowadays the total knee replacement is a very safe procedure, and we have a excellent the team of it's a teamwork actually. Teamwork containing the surgical team, the physicians, and the anesthetist, and then supported by the cardiologist and other team, and then the intensive. And with having a excellent the protocols, and then the fixed this one, so we have an excellent item, and we say it's a very, very safe procedure to undergo a knee replacement.
Is it painful procedure?
No, as I was discussing earlier, nowadays the total knee replacement is a very, we can say the painless procedure. We can say very minimal pain when they are little ambulating or when they are doing little physiotherapy. So otherwise, so with the very advanced techniques by our anesthesia team, so the regional adductor blocks and the pain management systems, so we keep the patients in a very comfortable zone, so without having the pain.
What is fast track knee replacement?
Fast track is basically nowadays everybody is talking about, and everybody is looking at it even in the internet also. So this with the current advanced techniques and the technology, and then the advances in the pain management system, and with the very minimal requirement for the injections to control the pain and other medications. So the patient will be very comfortable, and usually we do the surgery in the morning. Majority of the times we do make them walk in the evening, or at the most maximum for some reason we're not able to, and we next day walking. In 48 hours they are at home. So this is what usually the current trend of what is called the fast track knee replacement. So this is we are able to achieve only mainly because of the navigation technology and the good pain management.
Can the patient undergo both knee replacement at the same time?
Yeah. And this is a very common question and things on the discussion. When the patient has severe pain or deformity or severe osteoarthritis of both knees, if the patient requires both knee replacement surgery, usually generally we have our set of standard investigations to do. We get all of them assessed, including their cardiac status, lung status, and the generalized. Once we are happy with all the medical fitness and things on, and if the anesthesia physician and the surgeon team decides, okay, the patient is fit for both the surgery, and it is safe enough to do both knee replacement surgery at the same time. If patient has some medical issues, saying some low cardiac ejection fractions, or some pulmonary dysfunctions, or any other medical issues, we prefer doing one at a time, and then we give a minimum gap of around 6 weeks to 2 months minimum, and then we can do the other knee little later date. So again, the patient's fitness is more important to do both knees at the same time. And we have been doing both knee replacement at the same single sitting very oftenly.
How early can patient resume activities after surgery?
Yeah. Majority of the times, usually after the surgery, 1 or 2 days the patient will be up on their feet. They'll be walking around with the walker, and 80 to 90% of the patients, they don't need a walker at home. At discharge, they just need a stick. Some patients, mainly for the balance, if they have a severe deformity, we ask them to use a walker. By 2 weeks, usually they can resume their basic activities, stand and do the small kitchen works, start little going outside and things on. By 1 month, they'll be able to do their 90% of their normal work. including cooking, including going out, walking up to 1 kilometer, and attending the social functions, so stair climbing, so all those things can be. Usually what we say is the 90% of the recovery will happen by 1 month, meaning 90% of the work what they are doing 20 years before they can do at 1 month. Another 10% of the activities like little walking for more distance, running, so jogging, all those things will take little time, like 3 months. By 3 months usually they can walk unlimited distance, they can climb unlimited floors, and they can stand for long time, and they can do all their normal regular activities.
What are the common complications after surgery?
Yeah. So this is a very good question. Basically we commonly come across the most common is infections. Second is the so-called the clot formations in the legs, DVT, and third is actually the lungs issues. So usually infection nowadays with the present advance in the operating theaters, we have a very well equipped laminar theater, so which will prevent one of the major the advantage in the infection control. The second thing is and we use all disposable material, use and throw. So with the use of all this technology, the infection we can say is zero. The second thing is the DVT, means the common called as the clot formations in the legs. Usually this again we use the blood thinner injections to prevent the clot formations, and then we use a lot of mechanical compression devices to prevent these clot formations. And third, the most important clot formation prevention is the early mobilization. Patient starts walking on the same day or the next day, 99% of the clot formations will not happen. The clot formation risk becomes higher when the patient doesn't walk for 2 to 3 days. So these can be prevented by the injections, early mobilizations. That way.
Any contraindications for knee replacement in diabetic patients?
So diabetic, anyway, we commonly come across the diabetic is again going to become the common associated issue. We see 7 out of 10 knee replacement patients will be diabetic, to give the rough idea. So presence of diabetes is not the contraindications. Usually we assess their long-term sugar control by the HbA1c, and then the FBS, PPBS, and at least the diabetic has to be well controlled. Even in the HbA1c, the so-called the 3 months average control sugar, we expect it to be less than 8. If it is more, so then what happens in the diabetic, usually the chances of infections are a little higher. But anyway, we take utmost precautions. Usually our physician team will put them on proper diabetic medications, get the diabetes under control, and then we take them for the procedure. And again, we've been doing a lot of diabetic patients, and still now we have never had any issues.
How long they require physiotherapy after surgery?
Yeah, majority of the patients with the current technology what we are using, the physiotherapy requirement is very minimal. We are going to give them the set of exercises at the discharge, and then most of the time they can manage at their own. So physiotherapy involvement will be very minimal, maybe about 7 to 10 sessions of physiotherapy just to help them, and then they assist in getting the movements and things on. Otherwise, majority of the times, so our lot of patients who come from the rural areas, actually they go back after the surgery on the 5th day, and majority of these patients are not accessible for physiotherapy. And what the exercises we give them, actually they have been doing well, and they have been doing excellently well.
What is the success rate for total knee replacements?
Yeah. So usually we say now the 99% of the success rate in the present technology and things on. So the usual 99% of the patients are very well satisfied. Okay. And we can say the 100%, but only in the medical knowledge field we cannot say 100%. So we always 99%.
Thank you for your time, sir.
Right. Thank you. Right. Thank you.